Great. So I'm here with Dr. Fan from RCTX.
Thanks for having me.
Thank you so much for meeting with us and for tuning in.
Yeah.
And so we're here at COPHy, and I was just wondering what your thoughts are on the meeting and the kind of the style of the debate versus more of the traditional kind of lecture thought of COPHy.
I actually love the vibe. I love the feeling here. It's more relaxed. I feel like people really give their honest and true opinions, and there's a lot of back and forth. It's a tighter, more, closer feel in the audience. So I think that is what generates that type of discussion. But it's been really great so far.
Yeah, great. Yeah. And I agree. I think the discussion has been also a lot more lengthy than maybe in some other conferences where you're very tight for time. Has there been a certain discussion point that's kind of made you think a little bit and hum and haw and maybe you want to all over?
The session we just got out of about anti-complement agents, I think, was a pretty hot topic, and that's always been a hot topic both in the U.S. and ex-U.S. So it was really great to see, Barry Cooperman talk about his experience with the medication and kind of contrast that with how we've been dealing with it in Houston. So I think that will continue to be a very, hot topic as we move forward as well.
Yeah, and I think another aspect of U.S. and ex-U.S. is also that you get access to drugs first before anybody else does. So you have this trial period where when you come to these conferences, a lot of people want your thoughts. I know you just did a session on 8 milligram of aflibercept. Is that something that, what are you able to share with kind of the rest of the world in relation to aflibercept 8 milligram?
Sure, yeah. I mean, we have used a lot of aflibercept 8 milligrams in Houston just because of our access to the medication, and honestly, really just believing that some patients can benefit from it, especially those patients who have really recalcitrant disease that keep coming to our clinics every 4 weeks. And so being able to sort of pivot them to a newer second generation medication that can lengthen their time between visits, I think has been really empowering, just also, not just for the clinician, but also important for the patient as well, to not have to keep coming back, keep asking their family members to bring them back, and all of that stuff. So it's been a great experience so far. I love sharing our real world cases. We have many of them, but sort of bringing the best ones that we have to show.
I was going to say, the one that you presented at the Speaker's Corner, it really was a jump scare, because it was obviously someone that was lost to follow-up, came in with really bad, a very high level of CST, and then immediately being dropped down. Yeah. Was that some of those cases that then gives you the confidence to say, okay, I actually do believe?
Right, yeah, and especially I think with diabetics, patients who have diabetes often have a lot of other medical complications, and they may be admitted for a certain reason, or they may, miss their appointment because they have dialysis or something. And so being able to have something that can bridge that time period, and let's say they do get lost to follow-up for a few weeks, and you don't feel as anxious if you've got a longer acting, more durable medication on board. Yeah.
And I guess the last thing that's also been a hot topic is AI and the use of AI in imaging. How are you using it in your practice, and what are maybe some of the tools that you're hoping to kind of get your hands on as well?
AI is a very hot topic right now. I've got a colleague of mine, Dr. Al Krasan, who's heading up our AI initiative at RCTX, and the most obvious choice right now is for GA, geographic atrophy and macular degeneration, and how we can utilize anti-complement medications to help with GA or identify patients that would benefit the most from those. I'll be honest, my practice doesn't have a whole lot of anti-complement, but I think that if we can identify patients that would truly benefit the most from it, I think that would increase potential usage, not just in my practice, but across the board. I think utilizing AI to also predict who will progress more in terms of geographic atrophy will be really important. So from day one, let's say you have a patient with non-subfoveal GA, being able to tell them, hey, this is what AI predicts your progression liability to be. Are you going to have foveal threatening lesions within 1 year, within 5, is it 10? Then you can kind of tailor your medication and personalize that medication to every patient. So I think that's probably the lowest hanging fruit for AI right now in the field.
Great. Thank you so much for getting your thoughts on everything. And thank you so much for speaking to us.
Thanks for having me.
Tune in for more.
clinicianlink.ai.